Pann, Siama database advancing gastroenterology practice in Myanmar, current training pizza direction council sharing the BYA resource of operation.
Okay. Good afternoon, everyone. I'd like to say heartfelt thanks to our respectable chairperson for allowing me to take part in this academic CME program, and also Summr for sponsoring us with this academic program. And also, I'd like to say heartfelt thanks to our rector, head of department, and all the attendees for sharing your precious time, especially in this pandemic situation and the crisis situation. Today, I'd like to discuss about the title regarding the advancing gastroenterology practice in Myanmar, current trends and future direction. This is the outlines of my presentation. Because of the importance of GI disorder, it has a high global prevalence, and so we have to put a great effort by advancing our gastrointestinal care to cover our optimal patient care globally. So with the advancement in all areas, including minimally invasive techniques, enhanced image mortality, and innovative procedure, our gastroenterology practice has also begun advanced, especially in the areas of therapeutic endoscopy, retrograde cholangiopancreatography, endoscopic ultrasound, endoscopic ESG and EMR as previously described by Xiao, and also test-based endoscopy, oral endoscopic myotomy procedure. Let me discuss our advancement with the same case example. In the therapeutic endoscopy area, what we can do is the endoscopic management of GI bleeding, polypectomy and mucosal resection, dilatation and staining of stricture, foreign body removal, endoscopic treatment of premalignant conditions like caldera, esophagus, and early cancer. In the management of GI bleeding, we have the injection, Summr technique, mechanical and contact measure endoscopic theory to control the GI bleeding. This is our cases done at the Iternational General Hospital, case of decompensated disability of liver with hypertension came with the upper GI bleeding. He has a large esophageal varices with sign of recent bleeding like the red weight, and so we can perform endoscopic band ligation to stop the bleeding and to prevent further bleeding attack. And likewise, in the gastric varices, we can directly inject cyanoacrylic glue into the gastric varices to solubilize and clot formation of the blood within the varices. In case of gastroenteric vascular atresia like mucosal bleeding, we can use the plasma coagulation to create the mucosal fibrosis and prevent further bleeding formation. In case of colic, we can use polypectomy, either Posner or Hofstede polypectomy, and match volume with suspended blood vessel in the stop. We can perform endoloop and getting the endoloop removal of the anti-embolic can be done. This is the case performed by our professor via using endoloop and polypectomy. In case of stretchering, either benign or malignant condition, we can use metal standing across the stretcher side to maintain the luminal patency. And this is the case then for the esophageal carcinoma, putting a metal stand across the stretcher side to maintain the luminal patency. So in case of foreign body injection, especially occur in children and some metallic reject patient, we can use foreign body removal as a therapeutic endoscopic measure. This is a case done in our hospital by our professor. This is acquired accidentally injured at the 3 years old baby. While in the esophagus is safely removed by graphene faucet. So we can use other material like nets, grasping device, open tube, retriever baskets, and snare retriever depends on their types, sharpness, and size of the ingested foreign body. And another advancement area I like to focus is the ERCP, what we call is endoscopic retrograde cholangiopathiography. In the ERCP area, we can perform stroke extraction, choledocholidiasis management, endoscopic sphincterotomy and sphincter dilatation, biliary and pancreatic duct setting, management of findings and cause of complication, and in diagnostic role, we can use breast cytology and tissue sampling of the malignancy in case of suspected cholangiocarcinoma. This is the elderly lady, 72 years of age, presented with the obstructive jaundice, and on imaging, she has the obstructive biliary stone, and she is also not willing to proceed and not fit because of her comorbidity, and so we proceed ERCP, and here we can see the feeling defect in the biliary tree with dilated biliary tree, and on dilatation of the tract, just the tract with the EST and balloon sphincteroplasty, and or extraction, many soft stone and slash up, camsals and CBD was clear, and so the patient's obstructive jaundice and cholangiohepatitis features are released soon after the procedure. Likewise, this is another case with the obstructive jaundice CBD stone, and we can dilate and remove the obstructive stone particle and can avoid the unnecessary surgical intervention. In case of stricturing, we can also use dilatation with the sphincterotomy like this. We can use the sphincterotome with the letter, and we can use the Godfrey setting, and sphincterotomy can be done at the distal stricture, and we can also perform the balloon sphincteroplasty for the stricturing condition. This is the comorbid stricture with the upstream dilatation of intrahepatic duct, and we dilate the stricture site and put a stent across the stricture. And also, in case of periangular tumor, the groove is at the ampullary area, and here cholangiography shows grossly dilated CBD with the distant heroin. Here we can take biopsy to confirm the diagnostic of the periangular adenocarcinoma, and also we can put the stent to relieve his obstructive jaundice before going to the specific surgical management. After surgical procedure and some post-cholecystectomy cases, this is a 42-year-old patient presented with the obstructive jaundice. He previously performed cholecystectomy procedure 6 months ago with a choledochoroidectomy openly, but he had the obstructive slash particle in the site, and also dilated CBD is there. So we attempted the ERCP and CBD clearance, and soft stone coming expected, and the patient was his cholangiohepatitis and obstructive jaundice was also released after the procedure. This was also another lady, immediate post-cholecystectomy. She again presented with the obstructive jaundice, and here we can see the small radio-opaque stone at the distal end of the CBD, and we can remove via ERCP after post-cholecystectomy operation. In another area, I would like to focus our advancement is in the areas of endoscopic ultrasound. What we can do by EUS is in the area of tumor staging and lymph node assessment in taking tissue via FNA needle and co-biopsy and pancreatic cystic evaluation and training procedure. And for pain management, we can use CDF classes, blockage, or neurolysis. In tumor staging and lymph node assessment, we can use real-time image of the lymph node, and we can guess either benign or malignant structure, and we can also take biopsy if there is suspicions. For pancreatic cyst lesion, this lady came to us with previously she was treated with as the pseudocyst of pancreas. Initially, her lesion size was around 1 centimeter, but recently there was increase in size, and so referred to us for the EUS diagnosis. And during the examination time, her lesion was about 3 centimeter, and so because of the indeterminate size, we performed the aspiration of the pancreatic cyst lesion, and on examination, we can see the mucinous protrusion lesion, and because of our high malignant potential, we can send for timely referral for surgery. In case of subepithelial lesion, here's the case examiner of the 64-year-old lady presented with the dysphagia, and on screening by our professor, she had subepithelial lesion, and on proceeding to the CT abdomen, she has a gastric esophageal lesion on the lesser curvature, and on EUS assessment, here we can see the large esophageal subepithelial lesion on the lesser curvature of the stomach, arising from the fourth layer of the stomach. And we can perform needle biopsy from the lesion, and here we can see the spinal cell to get for the gastrointestinal stomach tumor. In case of large pancreatic cyst lesion, we can also perform not only diagnosis, but also we can perform the training procedure if there is indication, if there is persistent symptom and left side more than 6 centimeter, complication and suspicion of malignancy. This is the case of large pseudocyst with the obstructive symptoms, and so we have performed the pseudocyst training by putting the blood stent because of there is minimal necrotic debris. We can use the blood stent. If the necrotic debris is more than 30%, we can use Gadestat instead. For the pain management, especially chronic pancreatitis with the intractable pain, or depending on the high dose opioid or malignant pancreatic carcinoma, we can use the CDF laser blockage or neurolysis for pain management. And here is the aorta and CDF SMA, and here we can see the CDF ganglion, and we usually focus to this CDF classes to ingest the neurolytic agent, either bupivacaine, triamcinolone, or Iternational, for pain control. This is the case we done for the nodular pancreatitis. He has significant visual analog pain score of 8 to 9, and also have to depend on the high dose of opioid infusion, and so we have performed CDF laser blockage. And soon after the procedure, he has significant pain relief within 24 hours, and most of the patient within 24 or 48 hours, and the pain control was significant, and we can reduce the opioid usage in most of the time, and to the opioid-free periods, we can test up to years. And other advancements in our Myanmar Gastroenterology Center include spine glass cholangio, pancreatoscopy, and test feed, oral endoscopic myotomy, and HR manometry, balloon endoscopy, and laser lithotripsy are also available and developed in our Myanmar center like the Myanmar specialty hospital. So one of the challenges we are facing at the current time, we still have the limited access to advanced technology, and there can be the potential complication with the advancement of the procedure and varying degree or expertise among the endoscopists. So to solve these challenges, we have to improve our healthcare infrastructure, ongoing training program, adoption of new Pann technology and collaboration among our healthcare professionals like our surgical colleagues, radiology, and anesthetic counterparts. About the training and education, we have to enhance training education program in keeping up to date with the technological advancement, and we have to promote continuous professional development sessions like CME provided here today, and also hands-on workshop program. So here is our journey, setting off our achievement in our center. Our professor, our mentor started with the hands-on training from the international expert and sending young gastroenterology like us to the advanced center and also develop our center and also our foundation, Geneva Foundation and Geneva Society provide us a learning opportunity with the international meeting and training and hands-on program. About research direction, we have to focus on evaluating the effectiveness and safety of our advanced techniques by exploring the local clinical outcomes and establishing and adapting international practice to suit with our local regional Myanmar context. We have to collaborate with our global health organization and we have to assess resources and training to improve overall healthcare quality. So as a future advancement, AI has become popular in all the areas, and so as our gastroenterology also with the AI system and AI directed detection and AI directed advancement in all areas are staying on the pipeline for the future advancement. So as a conclusion, our updated therapeutic scoping techniques play essential role in diagnosing and treating GI diseases in Myanmar and enhancing patient outcomes and safety, and so this will position Myanmar as a growing hub for innovative healthcare solution in the future. Thank you for your kind attention.
Advancing Gastroenterology practice in Myanmar. Current training future direction council in sharing the Bivado, Siama, Dr. Basin, and Jisubin Shivaration. Pann season Italian, Summr traditional community project video show that Bivado preparation.